ultrasound remains the primary diagnostic mode and non-contrast CT is the investigation of choice to diagnose the urolithiasis. Almost all the stones are picked up by CT except the stones caused by the anti-HIV treatment drugs. Other investigation we do is urine sample, we look for increased number of RBCs more than 10 cells, WBCs more than 10 cells. If the WBCs is there, we should think of associated infection, then appropriate urine pH. If the urine is more acidic, we can think of a uric acid calculi forming. The blood, we look for urea creatinine, uric acid, calcium, phosphate, and we look for total count to look for whether there is any associated infection or not. If an intervention is planned, we look for the signs of any bleeding diathesis. Once the patient passes the stone, we almost always analyze the stone. It's usually by X-ray crystallography method. It tells what's the type of stone formed so that we can put the patient in appropriate medication in prevention. Like we do biopsy for all the surgical cases, for all urological stone cases, once the stone is removed, we send it for stone analysis. In pregnancy, ultrasound is the imaging modality of choice due to the non-radiation aspect of it. MRI can be done in selected cases. MRI, as we all know, works on the principle of the water molecule content in the structure. Stone doesn't contain many water molecules, so stone is not usually seen in MRI. We will look for sine qua non signs like any signs of obstruction, perinephric stranding, or urinoma formation in MRI. In pregnant women, low dose CT can be tried in very rare cases. Pediatrics, ultrasound again is the first line of investigation. If we are not getting any proper knowledge or idea about the stone, then we look for any CT or X-ray. In ureteric stone disease, the drug of choice is still NSAIDs, but as we urologists, we prefer tramadol because the basic etiology of urolithiasis is there is decreased GFR. So whatever NSAID we are going to give is also going to decrease GFR. So we don't prefer it as a first line. We prefer tramadol followed by IV paracetamol. If both not working, we give NSAID. We rarely give 2 doses of NSAID once in 2 months or 3 months. If the patient is having a recurrent colic, we use alpha blockers also. This relaxes the ureteric smooth muscle and decreases the frequency of colic. The most dreaded thing with stone is sepsis. Once the stone is associated with obstruction and infection, we should relieve the obstruction because any stagnant urine is a good culture medium. So we place either a stent or a percutaneous nephrostomy to relieve the obstruction. If the patient comes with a stone disease, we follow them with the ultrasound or a CT once in 6 months. If it's a small stone, it's not causing symptoms. And if the ones following up stones, if the stone is increasing in size or the stone is causing obstruction or if it is associated with infection or acute or chronic pain, then we will do surgery for such stones. The treatment modality, we have shockwave lithotripsy, percutaneous nephrolithotomy, RIRS and laparoscopy. We hardly ever open for stone nowadays. First line of therapy is medical expulsive therapy. 95% of stones up to 4 mm pass within 40 days. But we stretch the size up to 6 mm or 8 mm for medical expulsive therapy. If there is no evidence of sepsis, if the patient is having a good renal function, then we give tamsulosin or usually tamsulosin with IV fluids and analgesics to aid the passage of stone. For very large stones, ureterolithotomy, laparoscopy is recommended, but with the now advanced laser, it can still be managed with laser in 1 or 2 sittings. Laparoscopy can be either a transabdominal or a retroperitoneal approach. This picture shows percutaneous nephrolithotomy. That is, we access the kidney through the skin, we puncture the parenchyma, we enter the pelvic calyceal system, then dilate the system, we put a sheath to prevent bleeding from the renal parenchyma, then we pass a scope and break the stone and remove the stone through the sheath. This is a CT showing. Here you will see the stone. This is a very large stone, around 3 centimeter size, renal pelvic stone. As I showed in the figure, we puncture the kidney with the, this is the passing of guide wire in the ureter. Then the ureteric catheter is passed. Then we puncture the kidney with needle, then dilate the tract. This is inside the tract. This is the guide wire. This is the stone. This is being pulverized with the lithoclast. This is the guide wire. This is the stone which has been broken. This is a tri-pronged forceps. With this, the stone piece is removed gradually. Then since it's a large stone, it's taking quite long time, but it's relatively breakable stone. This yellow stone without any black discoloration usually breaks well. There is associated blackish discoloration, the stone is bit difficult to break. This is the DJ stent which is inserted after clearing the stone. அடுத்த next. If we have any difficulty to assess the ureter from the below, what we will do is, we will do a percutaneous tract. Through the tract we will pass the guide wire. Through the guide wire, antegrade we can pass a flexible ureteroscope. This ureteroscope can reach up to mid-ureter, and through the ureteroscope we can pass the laser and break the stone. This is another usefulness of the antegrade, that is percutaneous nephrostomy approach. This is retrograde. Through the bladder we reach the kidney through a flexible ureteroscope. This is a pediatric patient. The stone was not seen here. So I was searching for the stone, then I injected dye. It was only the upper calyx which is being opacified. Then I came into the pelvis, then there is the lower calyx, the stone was here. With the scope we broke the stone and we put a DJ stent. So Siam is a must for urologist, because if you go by vision alone, I would have put a DJ stent and come out. Since we had a Siam, we could visualize as another stone in another moiety, we were able to clear this stone. This is a 9-month-old baby. This is my finger appearing like a femur. See, even in 9-month-old baby can form stones present with hematuria. We have cleared in such cases without scar. We have passed a flexible ureteroscope and pulverized the stone with laser. This is the new kidney block. With the flexible ureteroscope and laser, we will break the stone, but there will be difficulty in clearing the stone because the stone will be broken to small dust. It will take sometime months to clear. It will be difficult to answer the patient. Now what we have come with the fans access sheath. That is, you use a flexible navigable access sheath, break the stone with laser, and you use suction in the access sheath to suck out the powder. See, now with laser we are breaking the stone. It's quite a large stone at around 1.5 to 2 centimeter in size. We are pulverizing it with laser. Now the flexible access sheath. With the flexible access sheath, we are sucking out the stone pieces. Access sheath is a long tube which goes from the skin to the kidney through the bladder. And then we connect it to the suction. See, the fragments are coming out. So we can clear all the fragments. This is the DJ stent after complete stone clearance. Next slide. This is the good old ureteroscopy. We will do a ureteroscopy. We will see the stone. This is with lithoclast. We break the stone into multiple pieces. After breaking into reasonably small fragments, we will use a basket. Now we are still breaking the stone. After breaking into reasonable small fragments, we will use a basket, Dormia basket. See guide wire that's passed. Now the scope is passed again. Basketing illa miss agudhu. Then we will basket out all the fragments. Next. This is a large ureteric calculus. This is the ureter with the large calculus. This is a retroperitoneoscopy. You can see a large amount of fat. Then the ureter is incised. Next slide. Then the stone is delivered out. Then we put a DJ stent inside the ureter and suture the ureter and leave a drain. In laparoscopy, during laparoscopy, if your patient is having a PUG obstruction with stone, what we'll do is we do a laparoscopy, and during one of the 5 mm port we pass in a ureteroscope. This is a female patient with a large vesicoureteric junction stone. See, with the large stone, the problem is if it is the vesicoureteric junction in female, it will be very close to the uterine artery. And once you take the stone out, there is very chance of bleeding, and if you coagulate the bleeding at that time, there is a good chance of forming a ureteric stricture. And open surgery is also not warranted. So what we did was we vaginally approached the lower ureter. As we all know, lower ureter is close to the uterine vessels. This is a traction of the cervix, and with finger I felt the stone and dissected the fornix. Now the stone is removed vaginally, then the ureter is closed. This is another large vesicoureteric junction calculus, but unfortunately he is a male. So what we did was we did a cystoscopy and incised the vesicoureteric junction. We tried to, it was a case came before we bought high power laser. We had a low power laser. It was taking a quite long time. So then what we did was, after incising the vesicoureteric junction, we passed in a nephroscope and broke the stone. So same size stone, same position, but different sex. The treatment varies, but we have the gadgets to treat those stones. This is ESW, extracorporeal shockwave lithotripsy. This is the generator through which the ultrasound waves are generated. This is the coupling medium, water inside the balloon. This is the C-arm through which we localize the stone. This is the balloon seen as in the C-arm. the X mark in two angles, we localize the stone and break the stone. This is a pediatric case to a 3-year-old with multiple vesicle calculus. Since a 3-year-old, we cannot pass large scopes through urethra because pediatric urethra doesn't accept those scopes. So what we did is we filled the bladder with the 10 mm trocar. We punctured the suprapubically with the cystoscopic guidance. Then through the scope, we went in and picked up all the stones one by one. It was matrix stones mostly. It's very rare in pediatric cases, but I had the opportunity to deal with one such patient. This is another multiple large bladder stones. Play on Mandengo. This structure is stone punch. See, we have seen lithoclast, we have seen laser. This is a stone punch. This punch will crush the stone by to and fro movement, and we have cleared the stone volume of up to 7 cm with this stone punch. It's a very versatile instrument. It's a mechanical method to break the stone. This is we recently did case after we bought a large power laser. This is a 6 to 7 cm large vesicle calculus. The patient insisted he shouldn't have any incision at all. Since we now have a large power laser, we convinced the patient he has to undergo in 2 sittings if he doesn't want a scar. Through the laser, we pulverize the stone. Since it was 7 cm in diameter, it was really big. It took quite a large amount of time. See the beauty of laser, large high power laser, it just melts the stone. See, you are able to see black color discoloration, right? Such stones, it's difficult to break with lithoclast. Second sitting we did after 3 days. The residual stone was broken into multiple small pieces and they were basketed out. So there are many methods to treat stones, but the only method to prevent stone is increase your fluid intake. So increasing the fluid intake, it should be increased to the level of 4 to 6 liters. And we can see once the season changes from a cold season to a hot season, there's a sudden gush of stone patients because there is decreased intake of fluid in cold season. If it's continuing in the hot season, there is stone formation. So the main point is they should take increased fluid intake. Kidney is the toilet of our body. If you want a clean toilet, you should wash it more. Likewise, you have to take more fluids. Restricted intake of salt, it's not possible in our culture, but we can suggest them not to have food outside in the hotels, because in the hotels, to increase the taste, they add more salt. So to restrict the salt intake, we ask them not to take food outside. We normally don't take excessive animal protein, and we can give potassium citrate. It's the only available medication now. You can also give oxalobact. Since we are giving more bacteria, the protective bacteria which breaks down the oxalate in the intestine is also killed. If you give them as a probiotic, that can also prevent stone recurrence. Thank you.